My name is Brad McAllister. I'm a periodontist practicing in Portland, Oregon. I would like to welcome you to another educational module produced by a collaboration between the AAP and LifeNet Health. Today I'm going to be reviewing cellular bone allografts. First, a quick disclaimer regarding the content of this presentation. My review of cellular bone allografts will consist of three general areas: cellular bone allograft literature and characterization, clinical insights as they relate to cellular bone allografts, and specific clinical applications for use of cellular bone allografts. When reviewing the bone grafting literature, it is clear that historically the gold standard has been autogenous bone derived from extraoral sites, primarily the iliac crest and the tibia. The reason for this is several positives that are listed here in green: very predictable material performance, very rapid bone formation, sufficient volume, well-published results, and no disease transmission risk. Unfortunately, there are some negatives shown in red: the complex harvest, especially with extraoral sites, the limited supply intraorally, and there are several significant potential complications with both intraoral and extraoral harvesting of autogenous bone. A recent 2022 paper also discusses the variability with intraoral autogenous bone, the limited validation literature comparing intraoral with extraoral bone, and the literature showing bone marrow aspirate does not perform nearly as well as traditional extraoral harvest and should not be considered in the gold standard category. So what makes cellular bone allografts similar to autogenous bone? Well, it's the presence of all three contributing properties. Just like with extraoral bone, cellular bone allografts are osteoconductive. They have a scaffold. They're osteoinductive. They have the ability for molecular induction of bone formation. And they're osteogenic, the presence of bone-forming cells, which is critical to the rapid bone formation found with both autogenous bone and cellular bone allografts. There's a long history of use in orthopedics. A 2010 publication by Brandt in Plastic Reconstructive Surgery Journal showed rib reconstructions using cellular bone allografts. Probably the biggest use of these grafts is with spinal fusions, although many other uses exist, like ankle fusions. In a 2011 multi-center sinus study I was involved with, we compared bilateral sinus grafts and found that histologic cores taken on average at 3.7 months showed cellular bone allografts to have 33% vital bone versus 18% for the side treated with demineralized cancellous allografts, with a lower significant residual graft material in the cellular bone allograft group. This finding was confirmed with a similar sinus augmentation study out of Kentucky that was published in 2020. This slide shows all of the clinical publications on cellular bone allografts. As you can see, the dental field has produced many of the publications. Here I have shown in green the dental implant publications, and in yellow the periodontal regeneration publications. It is worth noting that cellular bone allografts have been called a variety of different names, which can make the literature search difficult. Fortunately, I have been involved in the cellular bone allograft research from the beginning, so this is a fairly complete literature list. What's the bottom line with all of this literature? Well, compared to conventional allogenic, alloplastic, or xenograft materials, cellular bone allografts show higher vital bone content and lower residual graft particle. The excellent performance of cellular bone allografts has been confirmed both histologically and radiographically. Cellular bone allografts are considered as FDA 361 minimally processed tissue from a deceased donor. After extensive cadaver screening and testing, bone is ground to the appropriate particle size, washed, and treated with antibiotics. The wash product removes immune-reactive cells like hematopoietic cells, which are preserving the vitality of mesenchymal stem cells, osteoprogenitors, osteoblasts, and osteocytes, which when implanted can rapidly form new bone. The materials are combined with demineralized bone matrix, cryopreserved, and not terminally sterilized since they contain live cells. Safety measures are extensive, with some tissue banks accepting less than 2% of donors during the screening process. Once accepted, there is rigorous testing, washing, and antibiotic treatment. Enhanced AATB guidelines govern the donor selection process and preparation requirements. I would encourage you to visit these tissue banks. You'll be impressed by their impressive quality control and commitment to patient safety. Proper patient consent is vital, so they understand how these products differ from others in terms of both performance and risk. This 2023 study by Gianellis Published in Cell Tissue Bank provides an outstanding cellular bone allograft characterization with more detail than ever published previously. This set of figures from the paper shows how in vitro experimentation using cells that were derived from cellular bone allografts produced mineralization faster than a mesenchymal stem cell control. Mineralization shown with the alizarin red can be seen as early as 7 days on the upper left. By 14 days, there's heavy mineralization from the cells derived from the cellular bone allograft. The mesenchymal stem cell control shown on the right shows no mineralization at these time points because there's no signal driving them to commit to the bone formation pathway. This gives further support to the importance of having committed cells in your graft for rapid bone formation. Recent advances include smaller particle sizes created by improvements in the processing to create particles in the 1 to 3 millimeter range. This is very helpful for the dental space. The reduced packaging size now means there is a 0.7 cc size available, which is helpful for the smaller defects found in dentistry. There has been improved cortical cancellous ratios for optimal dimensional stability and improved handling. This is through the use of demineralized fibers and putty forms. Interestingly, we have learned that committed cells, osteoprogenitors, osteoblasts, osteocytes, may outperform mesenchymal stem cells in bone formation since they are already primed to form new bone. Future bone developments like custom cellular blocks and recent developments like the smaller packaging size will continue to make cellular bone allografts an attractive option for periodontal and implant surgery. The presence of cortical bone in cellular bone grafts not only enhances space maintenance, but we now realize osteocytes help orchestrate our bone graft healing, much like found in fracture repair. This recent review outlines the critical role osteocytes play during healing. Clinical results show improved dimensional stability with cortical component present. In this periimplantitis case, you can appreciate the large volume of high-quality buccal bone created without a membrane or without the use of titanium mesh. In this sinus grafting example, you can see minimal graft slumping and excellent histologic evidence of new bone, shown at 4 months on the right. The red arrows in the histologic section show that there are many areas of new bone formation. I would now like to review some clinical insights and surgical procedures for successful use of cellular bone allografts. Many of these clearly apply to all surgery, but I've listed them for completeness. Tension-free primary closure using slow resorbing sutures after generous flap release is critical. Having no pressure from temporaries, a soft diet, use of NSAIDs, and head elevation will minimize swelling and damage to the surgical site. We typically consider contour grafts at the second surgery when placing implants. We published on this in 2022. You'll want to eliminate any larger sharp bone pieces, or at least reduce their size with rongeurs, especially if tunneling is the planned grafting approach. For periodontal defects, reducing the particle size even further with rongeurs can be very helpful. It is worthy of note that cortical bone is more difficult to do this, so it is a bit laborious with the rongeurs. While maintaining tension-free closure, you will want to overpack the graft to maximize the dimensional stability. For grafts where you're trying to get over 3 millimeters of augmentation, it's best to use titanium mesh or reinforced PTFE, and this will improve the space maintenance. You do want to avoid mixing or expanding cellular bone allografts with xenografts. Although I routinely use xenografts for contour grafting at the time of implant placement after initial grafting with cellular bone allografts, I only expand with large particle mineralized allografts when a small expansion of the graft material is necessary to fill a larger defect. Interestingly, this is a similar finding with BMP2, which has been shown to perform much better when used with allografts rather than xenografts at the initial grafting. Because these are live cell grafts, revascularization is critical, and performing cortical penetrations and careful preservation of the periosteum is important. Even though dimensional stability is improved with the cortical component of cellular bone allografts, overpacking is important as shown in this tunneling example. The center CBCT capture shows the initial overpacking to achieve the 3 millimeters of horizontal augmentation shown on the far right. I would like to now review the product use. You want to keep your graft frozen in your -80 freezer or keep it on dry ice in the shipping container until your surgery has been initiated. A rapid 5-minute thaw in 37 degrees C water will be critical, no hotter. This gives the best results. Once thawed, ideally you want to use the graft within the 2-hour window. If you have the cellular bone allograft in the 72-hour shipping container with dry ice and your surgery cancels, what I typically will do is keep the container full of dry ice by replacing it and then use the graft within the next week. It must never thaw until just prior to the implantation. Once the graft is thawed, you want to mix the particulate and the demineralized bone fibers for optimal graft handling. Once this graft contains live cells, it's important to have care considering we want maximal cell survival. Typically, we do not use membranes with cellular bone allografts. This saves cost and improves revascularization from the periosteum. Examples include horizontal augmentations, sinus grafts where no membrane is used over the lateral wall. Exceptions include where the graft containment is needed when there's very thin tissues, or in cases where buccal bone grafting around teeth is used, and there we'll use a collagen membrane to help protect the bone graft and to improve the soft tissue thickness. Prior to bone grafting, surface grafting is ideal if there's no keratinized tissue present and you're going to perform a larger graft. Use of periosteal membranes, use of perforated membranes or titanium mesh does allow for rapid revascularization and stem cell signaling from the periosteum. So here we can see a couple of examples of perforated membranes, and you can see the titanium mesh on the upper left. So the bottom line is more rapid revascularization equals improved cell survival, which equals more rapid bone formation. On the right is an example of a typical cell-occlusive collagen membrane where you can see the revascularization stops at the point of the membrane. So this eliminates any revascularization from the periosteum, which is why we don't want to have a cell-occlusive membrane unless it's absolutely necessary. We want to revascularize as rapidly as possible. Now, the periosteum has many benefits. It helps with graft containment. We see this in tunneling examples. There's going to be reduced graft penetration into the soft tissues if your periosteum is left intact. It's an immediate blood supply. This can deliver nutrients. It's a source of stem cells. It's also a source of revascularization. This is evidenced by the fact that titanium mesh is highly successful. Other examples include PDGF studies where they have shown without membranes excellent results, and in some cases actually better than with membranes. And there's the evidence shown in the success of tunneling. Ernesto Lee has done some nice work showing his SMART technique where he's been able to get some excellent results without a membrane using the tunneling technique, just having the periosteum intact and getting the benefits of the periosteum. So for maximal revascularization, one of the things that's important if there is pretty dense cortical bone is you want to decorticate. That's going to just help revascularize and get good bleeding into the graft. So there's a pretty significant horizontal and vertical defect, a patient that was hit in the face with a 2x4, significant trauma. And so here we're using perforated membrane, and there's our cellular bone allograft in place. Membrane over top. And this is coming back in at 4 months. The CBCT on the left shows the vertical augmentation in the center region, and you can see excellent horizontal width that allows for implant placement. Here's a case that's one of the clinical applications I'd like to share with you. This is using titanium mesh where I fabricated it during surgery. I did do a surface graft, pregingival graft prior to treatment. That's why we have that real nice band of keratinized tissue. I find that if we're doing larger augmentations, doing that prior to your surgery, this makes it a lot easier, I think, for suturing and to make sure you have good closure. Here's a shot at the radiographic evidence and the CBCT showing how narrow this ridge is. So here's the titanium mesh in place, fixated with screws. The graft is underneath, and this shows a CBCT. Here you can appreciate both the vertical and the horizontal augmentation that was performed. And at 4 months when the implants are placed, you can see we have some nice bleeding bone and adequate bone for placement of all 3 implants. There was a little bit of a deficiency on the anterior implant. This contour graft was placed for this implant. Here's our final restoration showing excellent keratinized tissue and a nice radiograph showing good crest to bone levels. Now, probably a better approach is to use custom CAD designed titanium mesh, which you can do before. This speeds up your surgery. This was recently published using a cellular bone allograft by Dr. Michael Hartman. Here he used the cellular bone matrix with the custom titanium mesh, and you can see the histologic core on the bottom where he showed excellent vertical augmentation and vital bone growth using the cellular bone allograft. So here's an example where we used the cellular bone allografts to treat a bone deficiency and a recession defect. I published about this in 2018, where we have kind of soft tissue and bone grafting needs with these complex recession defects with root prominence. This concept of using bone grafting along with some soft tissue grafting for treatment of recession defects is not new. Both Mike McGuire's group and Jeff Bennell's group has shown previously published cases where bone grafting was utilized to treat these recession defects, because we know that it's important to ideally regenerate everything, not just the soft tissues. The CBCT shows that significant root prominence exists, especially on the tooth that has the recession defect. And you can see on the far left, on the bottom, that there's probably 75% bone loss on this tooth. Orthodontics was initiated to move the teeth a little bit more back into the bone. Obviously, that's going to help with any procedure that we do. You can see the cellular bone allograft on the right. A membrane was placed, and you can see the CBCT with the bone graft placement. Soft tissue grafting was performed, and the flap was advanced. This shows the healing roughly 6 months after, and then 2 years after. You can see the patient doesn't have the best plaque control, yet we still have excellent soft tissue and bone contours. We've improved dramatically the bone on the facial of that tooth. It also has helped that orthodontically the position has been improved. So again, here we are pre-op, and you can see 2 years out, the significant bone increase by the use of cellular bone allografts and soft tissue graft in the combination. So peri-implantitis defects, we know, are another great example where it's very difficult to get good bone regeneration. Here's one that's especially complex due to the bone loss on the adjacent tooth. You can see that central incisor has a good 8 millimeter bone loss area interproximal between the implant and the tooth. So these are the toughest defects because there's not a lot of revascularization potential having both a tooth and an implant. So we want to use our best materials, and there's no membrane used. We utilized a cellular bone allograft. You can see it placed on the right-hand side. And this is the healing at 4 months, where we were able to completely resolve the defect around the implant. There still is a little deficiency on that natural tooth, but a significant improvement from where it was. Luckily, a low smile line, because since that bone loss on the central incisor is significant, there's not a chance of regenerating that papilla fully. So periodontal defects are another application of cellular bone allografts. I published this back in 2011. Here's an example from that paper. It is a class 2 furcation. You can see on the right, the neighbor's probe going in 9 millimeters. So a pretty dramatic class 2 furcation, probably a case that we recommended implant placement, but after discussion with the patient, they wanted to use the cellular bone allograft and see if the tooth could be saved. Thorough root debridement of course, is the critical aspect of this, and then placement of the cellular bone allograft with no membrane closure and allowing that to heal for 4 months. You can see on the two-dimensional radiograph on the upper right that the furcation appears closed, but that's always difficult to prove with a two-dimensional radiograph. So a CBCT was taken due to the early time nature of this case, and you can see complete closure of that lingual furcation with the CBCT evidence. One thing of note here is that there is also a PDL space, suggesting that a PDL was maintained, which is, I think, very important in our early days of experimentation with cellular bone allografts, is that we know that they work quite nicely around natural teeth with no evidence of resorption or ankylosis. Combination defects such as this one, you can see that there's a socket graft for ultimate placement of a dental implant, and you can see the pretty significant defect on that canine. So cellular bone allografts will work out quite nicely. On the left is the bone graft in place. On the right, you can see at 4 months, and we actually regenerated bone up and beyond where the original crest was for that tooth. So I'm not the only one that has shown results around periodontal defects. There's a case report in 2013 of a class 3 furcation defect fill by Dr. Paul Rosen. And then Dr. Gao and Fagan published some excellent work in 2018, a very large study looking at cellular bone allografts for periodontal defect fill. They also looked at combinations where they used the cellular bone allograft plus PDGF or plus membranes. And what they found is that there was actually no added benefit when PDGF or membranes were utilized. And that goes back to my earlier statements that the cellular bone allografts don't really need a membrane. They're going to have rapid bone formation. And to get the best revascularization, it's best not to use a membrane. So I don't routinely use a membrane when I'm treating the periodontal defects. So I'd like to summarize by saying cellular bone allografts are clearly an alternative to intraoral autogenous bone. Advances in cellular bone allograft products will continue to make this alternative attractive for implant reconstructions and periodontal defects. Cellular allografts can rapidly produce new bone and very low residual graft material. We have histologic and radiographic evidence showing this in multiple studies. Additional studies are clearly needed, and some are currently in progress. I'd like to now do the knowledge check portion of this presentation. Question 1, which of the following cell types are not found in cellular bone allografts? The answer is D, hepatocytes are not found in cellular bone allografts. Question 2, what is the shelf life of cellular bone allografts once they are removed from -80 freezer or removed from the dry ice they're shipped in? The answer is 2 hours. So once they've been thawed, we want to make sure that within 2 hours you have completed your surgery. Question 3. Which is not a required technique to maximize success of grafting with cellular bone allografts? The answer is D. Use of a cell and vascular occlusive membrane is not a requirement, and in fact, many cases will actually do better without the presence of the membrane. Question 4. What components can cellular bone allografts contain? The answer is D, all of the above. They can have demineralized bone, cortical cancellous bone, and periosteum. Question 5. Which of the following will provide the least improvement regarding dimensional stability of cellular bone allografts? The answer is collagen membranes. While collagen membranes do serve a purpose, they do not have the dimensional stability that is oftentimes needed in our very large grafting procedures. Well, that's it for today. I'd like to thank you for your attention.